Alright, so I'm picking off where I left off on the shoulder. So first we're going to look for asymmetry of the shoulder. We're going to look at muscle distribution. Look for any scars, look for any lesions, any surgery, anything like that. Patient does not appear to have any scars, any surgery, anything like that. So we'll go on to the palpation of the shoulder. So first we're going to palpate from the clavicle to the shoulder. This is going to feel for abnormalities. So I'm palpating from the sternoclavicular joint. Going to the acromion of the shoulder, just feeling for any abnormal bony prominences, anything like that. We can do this on both sides. And I don't feel any abnormalities. Do you have any pain? No? Okay. From there, I can have the patient abduct her arms, so I'm going to have her raise them out and up. Okay, any pain with that? Mm-hmm. We're going to do some forward flexion of the arms and raise them up 180 degrees. Okay. And then we're going to do some external rotation, so we're going to put our elbows out like that, okay? And then internal rotation, we're going to put our hands back and reach for the shoulder on the opposite side. And the patient appears to have full range of motion in her shoulders. Now we can check for some rotator cuff injuries or any rotator cuff issues. So we can check for the resistance of the shoulder. We're going to do the same exact things that we did just a second ago, the same motions. I'm just going to put some pressure against her and see if she can resist that and overcome it. So, I'm going to go out. She does good with that. Any pain? Okay. I'm going to apply some pressure here. Okay. And then, going to apply pressure. And she resists that. That's good. Okay. So, she did well with that, so I don't suspect any rotator cuff injuries with the patient. Now we can check the elbows. So I'm going to have the patient extend her arms and reach up and touch her shoulders. And again, do that one more time for me. Okay, and she does good. That's a good fluid movement. So I can also have the patient put her palms up and turn them in and out to check the elbow because we're rotating those bones in there. She does good with that. And then we can have her put her wrists up and kind of check her wrists as we go. And she has good fluid movement in her wrists. So I can palpate her elbow for any tenderness, any scars, anything like that, any swelling, joint stiffness. I can also do the same thing with the patient's wrist. So I'm just palpating, seeing if I can feel any abnormalities, any surgery scars, anything like that. Okay, and then I can feel the patient's hands. I can look for any redness, any lacerations. Feel for, make sure her skin's warm and dry, that sort of thing. Make sure that she's getting good circulation to her fingers, so I can press on each of her fingertips and make sure she has good capillary refill. Make sure that refills in like 3 to 5 seconds, and it does. She has good capillary refill. I can have her make a fist and then extend her hands a couple times, and she does good with that. I can also palpate for any deformities in the hand, which I don't feel in either hand. And then I can check the flexion of her phalanges, so I can just hold on one joint and have her use her fingers for me. And she does. She has good flexion in her joint. So she has good flexion in all her finger joints as well. I can assess carpal tunnel also in the patient, so I can perform the Durkin test, which I'm going to press on the nerve right here in the hand and ask her if she has any pain or numbness. What about in this one? Tingling? No? Okay. And then the Tinel test, so I can tap these same little areas. Any electric shock feelings? If the patient has carpal tunnel, she would be feeling like an electric shock sensation running down her hands if I did that. And then we can do the Phelan test. So we're going to keep our elbow straight, and then she's going to flex her wrist up while I press right here. Any pain with that? Numbness, tingling? Okay. So, patient obviously does not have carpal tunnel, which is a good thing. So from there, I can assess the hip. So I'm going to have the patient lay down. So make sure we got a good viewing angle, and we do. Okay. So first, I'm going to look at the hip, make sure that there's even distribution. I can palpate the hip, make sure that we don't have any swelling, tenderness, anything like that. I don't feel any. So I can have her flex her knee on her own. So if you could just flex your hip at a 90-degree angle. There we go. And with the other leg. So the patient does that well. No issues there. I can have her abduct her leg and come out to me. And back in. And same thing with the other one. Okay, and then I can have her adduct her hip, so she's going to cross that leg over the other leg. And that way too. Okay, and then I'm just going to log roll the hip and feel for the internal and external rotation. Make sure that her leg rotates as I'm turning it in and out. And it does. She has normal rotation. So I'm going to go ahead and do the same things we just did, but I'm going to do them passively and make sure that the patient can actually do them. Alright, so we have good passive and active motion of the hip. If she had any arthritis in the hip, this would cause pain to her. Did you have any pain? No. Okay, so if she didn't have any limited range of motion, so she doesn't have arthritis in the hip, the normal hip exam. From there, I can assess the knee. So I'll have the patient, well, I'll go ahead and assess the knee from here at this point. And all I'm feeling for is some tenderness, see if there's any inflammation in the knee, redness, swelling, anything like that. I can inspect the knee. You want to go ahead and raise up for me? Okay, so I can look at the knee, and she had her foot. I could look at it. I could look for redness, anything like that, surgical scars, lacerations, that sort of thing. So I can also have the patient walk for me, and I can assess her gait. And the patient has a normal gait. She did not limp when she walked either, and so that's a good sign for knees. So I can also have the patient sit down, and she is going to extend her knee out for me and put it back in. Going to make sure my camera can see what we're doing here. Okay, so she can do that on both knees, which is great. I can then have her lay on her belly. And I can lift her knee, make sure that she can move it, and then she can touch her heels to her butt. There we go, close enough. And okay, she does great with that. And then I can also check the bulge test in the knee. So I can look for, I'll put my hands on either side and look for fluid moving in the knee as I do this. And the patient does not have any fluid on the knee, so I don't see any fluid moving when I do that. That checks for effusion.